Dr. Saqib Hameed here from the Altamas. He's assistant professor, and I would like to ask him to please take a dice. Thank you.
بسم الله الرحمن الرحيم رب اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقهوا قولي. I would like to begin my talk with a word of appreciation and gratitude for the organizers of this event for arranging such a wonderful session of dental events. And of course, not to forget, thanks to my fellow speakers for arranging such a wonderful platform to start up with the cases for surgical endodontics. Okay, moving on with my introduction. This is the place where I belong to, Altamash Institute of Dental Medicine. This is the nursery of my knowledge. I joined this place back in 2006, did my graduation from there, did my first job as a lecturer in the Department of Oral and Maxillofacial Surgery, did my training in FCPS and did my FCPS training in operative dentistry and endodontics, then became the faculty member, and now I'm currently working as an assistant professor in the Department of Operative Dentistry and Endodontics. So moving on with the topic of today, the periradicular surgery. These are the learning objectives of my topic. By the end of this session, the participants of this CME session on the endodontics will be able to discuss the indications of periradicular surgery. They should be able to classify the periapical bone defects, and they should recognize the steps of endodontic surgery. I'll divide my presentation into two components. First, we'll discuss a bit of theory regarding the endodontic surgery. Then I'll present you a case of endodontic surgery step by step, and then we can recognize the steps as well. So the introduction about endodontic surgery. Surgical root canal therapy, including the root end resection, has been practiced since at least the mid-1800s. Since then, it continued to evolve into a practice biologically based adjunct to the non-surgical root canal therapy. The key point is adjunct to the non-surgical therapy. So what we should understand is the first line of action for any endodontic pathosis is non-surgical treatment, right? So we should always take this endodontic therapy, surgical endodontic therapy as an adjunct for the cases which are refractory, which are not being getting healed after endodontic therapy, or there are some complications into it. Like Dr. Jamshed has showed us so many good cases which he had actually treated with file retrieval or anything like that. But in case if we are not being able to treat such cases, then we are left with the options of endodontic surgery. Okay. So there are some reasons that can cause persistent periradicular disease. What are those? There are certain microorganisms that can survive in the dentinal tubules. There are canal irregularities, apical deltas, isthmus, which play a harbor, which gives a harbor to the microorganisms, and they can actually cause persistent infection. These are the cases where endodontic treatment may not provide us healing. Enterococcus faecalis, this is the main organism that is involved in the failure of endodontic treatment. Many of the students must be known about it. Do you guys have any idea what are the factors which lead to the resistance of antibiotics or the endodontic treatment for Enterococcus faecalis? What are the key features of Enterococcus faecalis which leads to non-healing of the cases? क्या Enterococcus faecalis की बातें होती हैं जिसकी वजह से वो ज्यादा failure cases में involve होता है? Resistance to calcium hydroxide, the main thing, ठीक है? Then it can enter into dentinal tubules. Again, we cannot actually eradicate many bacteria from dentinal tubules. There are these bacteria, they form biocolonies, okay, and they can even enter into a dormant phase. When they enter into the dormant phase, what actually happens is any antibiotic we place in the canal, it doesn't act on it, so the bacteria remain resistant, and we may face the non-healing of endodontic cases. In such cases, we may have to go for surgical option then. Then there are some overextended fillings which are going out of the apex, and we might have to do the apicectomy or endodontic surgical procedure. There are some periradicular cholesterol crystals or initial cases of VRFs, which can lead to non-healing of endodontic cases, and we may have to go for endodontic surgery. So this takes us to the rationale of the surgical treatment. These are the indications, the lesions that are not been healed, and we can do the surgical treatment. And the rationales are long posts. Sometimes there are posts which are present in the canal and we cannot retrieve the post, and we have to go for surgical option then. Then there are some irretrievable separated instruments, like Dr. Jamshed has shown us many of the cases. There are some non-negotiable ledges and canals. What do we do with them if the case is not healing? Of course, we have to go for surgical treatment then. There are some hard filling materials also which are not being able to retrieve from the canal. If we go for endodontic retreatment and the material is such that it is not being retrievable, how do we then approach it? We can approach it surgically then, okay? Then if there is a need of any biopsy from the apical area, we can go for surgical option. But having said that, non-surgical treatment still is recommended before surgical treatment to reduce the microorganism load from the canal. We first have to perform endodontic treatment. Only then we can move ahead with the surgical option. This is the radiograph showing a long post in a lateral incisor with a very adequate coronal restoration. We can simply go for endodontic surgical case because removing this crown, removing this post may lead to the fracture in the root. The viable option for this case would be a surgical approach going retrograde rather than orthograde. You guys get any idea of orthograde and retrograde? Orthograde is conventional entry into the canal from the coronal part, and retrograde is from the apex. Thank you. It might be, but if in such cases with such adequate restoration of the coronal part, we can just have a retrograde approach and still we have good amount of bone left in this case. So it will be a success, hopefully. So what do we see in this case? As Dr. Jamshed again pointed out, transportation and perforation, right? In the mesiobuccal root. Do we have a pointer? Yeah. So can we see a transportation in the mesiobuccal root? There's the apex of the canal. Okay, so there is a transportation and there is a lesion here as well. So what do we do in such cases? How can we treat it? Again, a adequate coronal restoration is present. Episectomy. See, episectomy has been done. The root has been resected from the apical area and we have placed an apical plug at the retrograde area, retrograde approach. And if we see the follow-up, see a good healing over there. The bone has regenerated. So moving on with the lesions of apical area, there is a classification known as Kim and Crackman classification. We have divided the lesion into 6 parts, class A till class F. Okay, so class A is the absence of periradicular lesion with no mobility, normal pocket depth, unresolved symptoms after exhaustion of non-surgical therapy. In this case, simple retreatment is fine enough. Class B, the presence of a small periradicular lesion in the apical quarter. Clinical symptoms such as discomfort, sensitivity to percussion and sinus tract, normal periodontal probing depth, and no mobility. There is a small lesion, periapical lesion. Class C, large periapical lesion, progressing coronally but without periodontal pocket. We'll see the diagrammatic representations here. Class A, no periapical lesion. Class B, small periapical lesion. Class C, a large periapical lesion but with no coronal communication. We can see the coronal area is still intact. Okay. Then moving on to the large lesions. Class D, which is clinically similar to class C but with a periodontal pocket of more than 4 millimeters. Then we have class E, which have a deep periradicular lesion with endodontic periodontal communication. I'll show it to you in the next slide. And then there is a class F lesion, which has complete denudation of the buccal plate. There is no buccal bone left on this in these cases. C, class C, there is a small periodontal pocket. Okay. Then there is a communication between the pocket and the apical lesion. And then in the class F, there is no buccal bone left. In these cases, class D, class E, and class F, we might have to go for guided tissue regeneration as well. Okay, once we are done with surgical endodontic treatment, we have to perform guided tissue regeneration, the bone grafting and the membrane placement. Okay, I'll show it to you in the case as well. So clinical decision making, what do we do? Again, अभी थोड़ी देर पहले बात हुई कि क्लिनिक कैसे चलेगा, इतनी मेहनत क्यों करें, इम्प्लांट कर दें, है ना? केसेस होते हैं ना इस तरह के, आपके पास डिसीजन लेना होता है, either to go for retreatment, either to go for surgical treatment, or to go for implant. So the decision making should always involve the patient's will. You should have been able to perform or to pass on the information regarding the prognosis of each and every option, and let the patient decide what he or she wants to have. Okay, the choice of the treatment should depend upon the evidence, clinical judgment, and patient's preference. Okay, of course, patient health risk evaluation. Any surgical treatment, the medical evaluation comes first. In fact, not only a surgical treatment, any endodontic treatment needs a good medical health risk assessment for the patient. We should just skim through it. Procedure. This is the diagrammatic representation of what we do in surgical endodontic treatment. If we see, we have gained an access by raising the flap. There is a large periapical lesion. Which classification this case falls into? Class C, yeah. Okay. There is no communication. There is a large periapical defect or large periapical bone lesion. So what we do, we actually raise the flap, gain access into the bone. This is the apical area which harbors most of the bacteria in apical deltas and isthmus. These apical deltas and isthmus, they harbors the bacteria and they lead to actually failure of the cases. So in such cases, we actually go for root end resection, the term apisectomy. We remove the apex, right? And why do we remove it? Because this area contains most of the bacteria in the isthmus and apical deltas. So we just remove it. And what do we do with the canal then? There is a canal over here. We have to make sure that the canal is sealed from the apex as well. Nothing enters into the canal from the apical side, right? So with such large bone defect, we might have to place some bone graft as well. Okay, that we'll discuss in the case. As with any of the surgical procedure, anatomy, you must know your anatomy well, because whenever you are dealing with any case surgically, anatomical factors do come into play, especially in our lower mandibular region, lower posterior region. What do we encounter with? The ID canal, the mental nerve, right? So we have to be very careful while placing our incisions in such cases. What do we face in maxilla? Sinus. We have to be very careful regarding it. Okay. And on the palatal side, there is a greater palatine artery, nasopalatine nerves and vessels. So we have to be very careful regarding placing our incisions, raising the flaps, and dealing with the bone and soft tissues over there. This is a clinical case showing a relucency in the radiograph, right in the midline. If we see, there is a neurovascular bundle being identified right in the center, nasopalatine nerve and vessel. Okay. So moving on to the surgical access, the surgical procedure that we do. The surgical access, these are the general principles of the surgery. You should know your anatomy well. You should have good visualization of the lesion. You should minimize the surgical trauma. Of course, we have to minimize it, right? So we involve minimum number of teeth that we can work on. We have to place our incisions on the healthy bone. You must not place any incision on the diseased bone, right? Soft tissue management, we have to raise the flap. Obviously, there are vertical incisions, there are horizontal incisions. I'll show the case and you guys will get a better idea of it. This is a very good flap, ocean beam Luke flap. This is generally done to preserve the papilla. What do we have in anterior zone? Aesthetic zone. If there is any aesthetic zone and we are performing surgery and we give incisions on the papilla, what occurs after healing? There is some recession, black triangles may face. So this ocean being Luke flap actually helps us to avoid such situations. Okay. There are full thickness mucoperiosteal flaps. There are designs of it. If we give one releasing incision, we say it triangular flaps, two releasing incision with a horizontal incision, trapezoidal flaps. Then we have freeform rectilinear submarginal, which is ocean beam. So hard tissue access, raise the flap, we get access into the bone. And what do we do with the bone then? We have to remove the diseased bone, the granulation tissue over there. And of course, when you are getting the access into the bone, you might have to create a window over there by removing a part of the bone. And whenever you are removing the bone, mind you have to make sure that you do not overheat the bone. You must drill the bone along with saline irrigation. Otherwise, if there is any increase in the temperature of the bone, it may lead to further necrosis of the bone over there. Okay. So management of the root end. We have gained the access into the bone. We have removed the diseased tissue, diseased bone, granulation tissue over there. Then we resect the apical part of the root, right? And once we dissect it, we have to do something with the root as well. We have to place some medicines. What do we do? Resection. What about the resection? As we see, a straight line, a straight green line. Traditionally, we used to give an oblique resection, but nowadays we do a perpendicular resection. Okay, they say that if you are giving an oblique resection, it might expose more dentinal tubules, and the load of the occlusal load might not share well. So we give a straight line, perpendicular root end resection. Okay. Root end being dissected, then what do we do with the root? We do root end conditioning. We have to remove the small layer from the root surface. And what do we use? Citric acid or tetracycline or EDTA. This is just to remove it because we have to seal this area, right? Once we are resecting and after resection, we have to seal it. And to seal it, we have to expose it well so that our material gets adapted well into this area. So we have different options of material that we use, and these root end material, I'll discuss it later. But first, how do we place our root end resection material into the canal? How do we place the material inside the canal to have a seal, the retrograde cavity that we have to place, right? Once we resect it, we create a cavity in the canal from the apical area, the retrograde filling material that we have to place over there. So what do? We actually prepare a cavity with a miniature handpiece in the apical side of the root, or we can use ultrasonic tips to create the cavity over there. Once we prepare the cavity, we do the root end preparation. We do this apical plug sealing. See this? We have done a case, raised the flap, took out the bone, root end resection has been done, and a apical plug has been placed by preparing a retrograde cavity. And these are the different materials that we use. Traditionally, there was amalgam being used to fill the apical area, but nowadays we do not use it anymore. We use more biologically active materials like MTA or biodentine. But these are the list that we get into the literature, but frankly speaking, we just use MTA or biodentine more of in these cases. So once we are done with it, we have to close that site as well. So radiograph should be taken before the flap closure to detect any remnants. Then we properly irrigate and curate the bone grafting in class D, E, and F cases. And then flap is repositioned and sutured it back. Okay. Can we have the next presentation, please? Okay. So this was the case. The patient was being reported to us for routine checkup, and we had a general physical examination and intraoral examination of that case. But when we saw the X-ray of this case, this was the lesion being present on her incisor and incisors, the right and the left central and lateral incisor. There was a big radiolucency, and there was a history of trauma to this case. So what we did a root canal treatment of this case. But since there was root resorption and such large radiolucency associated with it, so we opted for the surgical treatment then. This is the ocean bean luke flap. We can see the papillas are being preserved, and we have given the horizontal incision and two releasing incisions as well. The flap was being raised, and we can see the bone here. This is the bone fenestration. We get the idea that where is the defect, where we get the defect. This bony fenestration, this gave us the idea that where we have to start our bony window to create. We just get this fenestration over there, and we start removing the bone, a bit of it, with the help of slow speed round burr with a copious saline irrigation. This is the window being created. We can see the bone defect over there. See this large defect. The granulation tissue was being removed from this site. Can you guys see the apex of the root here? Okay, the GP is coming out of it as well. So what's next? Root end resection. Okay, so root end resection has to be done. Can you guys see this? Light thoda si aur band hoti hai, so we could have seen it more better. This is the root end resection. And can you see the center in the center line GP here? Okay, so what do we have to do? Root end resection, and then we have to prepare the cavity, right? The retrograde cavity. The retrograde cavity now has been prepared. Can you see it here? I'll show it to you in the next slide. MTA, the material to seal the apical side. Okay. See, the apical side has been sealed with MTA. What do we do with the large bony defect? Bone grafting. Okay. See this large bony defect present, but it's a healthy bone now. We can see fresh blood coming out of it. This fresh blood is important. When you get the fresh blood, only then you are sure that, okay, the granulation tissue has been removed. Regenos, bone grafting material. We are going to place this material inside the defect, mixing the bone grafting material and placing it in the defect. Okay. See, the bone graft has been placed very nicely. And then we are going to place the membrane. This is the membrane box. We have taken out the membrane, placing the membrane in the defect, over the defect. The membrane is placed. And what do we do next? Suture it back, right? So this is how we deal it. So once the healing is there will be no recession of the papilla, right? So this ocean bean luke flap really helps us a lot in aesthetic zones. This is the post-op X-ray. And if you want to compare it with the pre-op, see this lesion here and the lesion here. It's all gone. This root canal treatment nicely been done, and an MTA plug being placed at the apex with the bone grafting material. Okay. So this is our superpower. We can save the teeth, right? And can we have the video please on? This is the nice little message that I wanted to share with all of you.
सच्चे जुमले में तो मेरी लाइफ ही चेंज कर दी। और वो जो मेरी देखिए, कोई एक बाजुकात इंसान बड़ी किताबें पढ़ता है और बाजुकात एक जुमला। अब ये जुमला आप देखें कि वो आबिद इबादत करने वाला डॉक्टर जो अपने मरीज के लिए मुखलिस नहीं, उसकी इबादत उसे कोई नफा नहीं पहुंचा। अब ये इतना हो कि मैं अगर सिर्फ और सिर्फ, क्योंकि मुझसे तो अल्लाह मेरे मर्तबे का पूछेगा कि पूरे पाकिस्तान में चंद लोग थे जिनको डॉक्टर बनाया, अल्लाह नहीं बनाया ना। और फिर उसके बाद क्यों बनाया? कि तुम नाफे इल्म हासिल कर रहे थे जिससे मखलूक का नफा हो। अब ये बताओ कि कितने लोगों का नफा हुआ। कब्र में नेमतें देने वाला नेमतों के मुतल्लिक पूछेगा कि दी तो तुझे मैंने नेमतें थी ताकि तू मेरे करीब हो जाए, सही बात, तो मेरी नेमतें इस्तेमाल करके जहन्नुम तक कैसे पहुंच गए। और गाफिल की आंख तब खुलती है जब बंद होने वाली होती है। बल्कि एक और जुमला कि हम जिंदगी फिरौन की मांगते हैं और आकिबत मूसा की मांगते हैं। तो ये देख लेना कि अगर आपकी नमाज का अमल आपकी जिंदगी में जाहिर होना चाहिए। कोई शख्स तलाश करो जो तुम्हें दुआ दे, लेकिन एक शर्त है, उसे बोलना ना पड़े कि मेरे लिए दुआ दे, वो तुम्हें देखे और दुआ दे। उसकी जिंदगी में कुछ ऐसा कर जाओ कि वो तुम्हें देखे और दुआ। क्यों गुनाह खतरनाक है रूह के लिए जी। तो हम रूह और जिस्म की कॉम्बिनेशन है। सही बात। आज का डॉक्टर इसलिए पूरा कामयाब नहीं है क्योंकि वो सिर्फ जिस्म को फोकस कर रहा है। रूह पहले बीमार होती है, जिस्म उसको फॉलो करता है। पुराना बिलीफ यही था, जितने भी मुस्लिम जो हकीम थे, जो बड़े बड़े डॉक्टर्स थे, उनका ये बिलीफ था कि रूह पहले बीमार होती है, सही, जिस्म उसको फॉलो करता है. तो जब हम रोजा रखते हैं, खा तो कुछ भी नहीं रहे,
बिल्कुल,
लेकिन रूह स्ट्रांग होनी शुरू होती है और फिर जिस्म उसको फॉलो करता है.
क्या बात.
अभी रिसर्च है, 3 दिन का फाका, ठीक है ना, 3 दिन अगर आपने फास्टिंग की है
सही,
लॉन्ग,
सही.
और उसके बाद अगर आप मील लेते हैं तो आपकी बॉडी के अंदर स्टेम सेल मोबिलाइजेशन होती है.
अच्छा.
और जितने पुराने खुलिए हैं उनको नए सिरे से बॉडी बनाती है दोबारा से. ये स्टेम सेल मोबिलाइजेशन फास्टिंग के जरिए. और टॉफेजी 2016 या 17 का नोबेल प्राइज विन कर चुका है बंदा. तो कुछ भी नया नहीं है, बस वही पुरानी के जितना खुराक जरूरी है उससे खुराक से दूर रहना जरूरी है. और ख्याल भी एक खुराक है, सिर्फ रिस्क खाना पीना तो नहीं है.
बिल्कुल सही.
तो अब आप देखें कि आप अपने आप को किन ख्यालात से फीड कर रहे हैं. मनफी मनफी
बिल्कुल,
मनफी, वो थॉट्स बिकम थिंग्स. ये जब आपकी सोच इतनी नेगेटिव हो जाए ना तो फिर वो जिस्मानी शक्ल इख्तियार करती है.
So the take home message, do something for someone कि आपको देखे और आपको दुआ दे. And we are blessed with the power of healing the dental tissues. तो हमारे लिए तो we have the stage set कि patient हमें देखे भी नहीं और हमें दुआ दे. Right? The patient, once the patient is eating or he is comfortable eating, he can give say a word of prayer for us. Or if he's looking at his smile and he can say pray for us. So with this end note, I would like to conclude my presentation. Thank you so much. Of course, yes, non-surgical treatment is the first line of action. Clinical examination is the thing, right? You have to perform the clinical examination, perform the periodontal probing, see the radiograph, and then you can see it. CBCT, thank you so much. CBCT is, it depends upon the patient. Sometimes the patient can have, like this patient, she didn't have any symptoms at all. It was asymptomatic. Necrosis हुआ होगा. Necrosis तो लाजमी हुआ होगा. Necrosis के बगैर तो ही नहीं. Thank you.